In Western Sydney, a significant majority of patients with type 2 diabetes have a HbA1c greater than 7%. Evidence around current therapeutic guidelines and PBS restrictions is constantly changing, so it can be challenging to keep up with it. The 6 main classes of medications currently available for management of type 2 diabetes are biguanides such as metformin, sulfonylureas, GLP-1 agonists identified by their suffix "tide", DPP-4 inhibitors identified by their suffix "gliptins", SGLT2 inhibitors identified by their suffix "gliflozins", and insulin. Metformin is the first-line therapy unless it is contraindicated or not tolerated. It may also be recommended in pre-diabetes to delay progression to overt diabetes. It works by reducing release of glucose from the liver, especially overnight, and improving insulin sensitivity. If HbA1c remains above 7% despite metformin, additional agents may be required depending on underlying comorbidities and risk of hypoglycemia. Current PBS indication for second-line agents such as DPP-4 inhibitors, SGLT2 inhibitors, or GLP-1 agonists is a HbA1c above 7% despite metformin monotherapy. DPP-4 inhibitors and GLP-1 agonists increase incretin levels, resulting in increased insulin release and decreased glucagon production. These actions occur in a glucose-dependent fashion, hence carry a low risk of hypoglycemia. They increase satiety and delay gastric emptying through their effects on receptors in the central nervous system and gastrointestinal tract, and are a good option for overweight or obese individuals. The convenient weekly dosing of GLP-1 agonists can also improve adherence. SGLT2 inhibitors work by reducing the reabsorption of glucose in the renal tubules. They also help with blood pressure reduction and weight loss. SGLT2 inhibitors have proven cardiovascular and renal benefits and should be considered second line in patients with these comorbidities. The combination of GLP-1 agonists and SGLT2 inhibitors is a good option given their multiple clinical benefits. But the PBS does not allow use of this combination, so if prescribed together, one will need to be on a private script. Sulfonylureas facilitate insulin release in a non-glucose dependent fashion, hence carry a higher risk of hypoglycemia. They also have the disadvantage of weight gain. Consider commencing insulin for patients who have suboptimal glycemic control despite triple therapy or have a markedly raised HbA1c. Various national diabetes associations, such as the American and European Diabetes Associations and the Australian Diabetes Society, publish updated recommendations regularly. The American Standards of Care 2022 are summarized in the next 3 slides. Individuals with type 2 diabetes are at an increased risk of atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease. The selection of second-line therapy should be made to prevent progression of these comorbidities and reduce mortality. In the presence of atherosclerotic cardiovascular disease, SGLT2 inhibitors or GLP-1 agonists with proven cardiovascular benefits are good second-line options. If HbA1c remains above target, for patients on an SGLT2 inhibitor, consider adding a GLP-1 agonist and vice versa. In the presence of heart failure, SGLT2 inhibitors are recommended. Both SGLT2 inhibitors and GLP-1 agonists are recommended to prevent progression of chronic kidney disease, but in the presence of albuminuria, SGLT2 inhibitors are preferred. If hypoglycemia is the main concern without the aforementioned comorbidities, then use DPP-4 inhibitors, SGLT2 inhibitors, or GLP-1 agonists. Where weight is the main concern, GLP-1 agonists are preferred. Metformin is known to have gastrointestinal side effects, but these can be reduced by taking it with or after food or switching to the extended release formulation. GLP-1 agonists may cause gastrointestinal side effects, however, these usually resolve after a few weeks. SGLT2 inhibitors are associated with a small risk of genitourinary infections. Due to the risk of euglycemic ketoacidosis, it is important to educate patients to withhold these agents when they're acutely unwell or 3 to 4 days prior to a planned medical procedure that requires fasting. In summary, lifestyle intervention and metformin are the cornerstones of managing type 2 diabetes. Second-line therapy should be determined by pre-existing comorbidities, and if glycemic control remains suboptimal despite triple therapy, insulin should be considered.